Greetings and welcome to today's webinar on information technology tools to support the scale-up of viral load testing and early infant diagnosis. My name is Jennifer Pearson, and I am a technical advisor on the AIDSFree project. Before we begin today's presentations, I'd like to quickly review the Adobe Connect environment and set a few norms for today's webinar. Today's webinar has 3 presentations, followed by a discussion period, during which our speakers will address your questions. Within the webinar environment, please make use of the Q&A box on the bottom right side of your screen to share your thoughts, note your questions, or ask for help with sound during the presentation. Questions you ask are only visible to you, our presenters, and technical support. If you are experiencing difficulties, our technical support will respond to your question privately. We will collect your questions for our speakers and will save them for the discussion period. It is great that we are able to connect people from so many places today, but your experience may vary based on your internet connection and computer equipment. I will briefly go over a few troubleshooting steps if you have technology challenges today. A few troubleshooting tips. If you lose connectivity or cannot hear, close the webinar. Re-enter the meeting room in a browser other than Google Chrome by clicking on the webinar link provided. Use the Q&A box to ask AIDSFree Tech for assistance. If the troubleshooting steps are not successful, please rest assured the webinar is being recorded and you will receive an email with a link to the recording following today's event. The recording will also be posted on the AIDSFree website. Questions that don't get answered during the Q&A sessions will be compiled after the webinar, shared with our presenters, and responses from the presenters will be shared with participants and others via the AIDSFree website. To get us started, I will now turn it over to our moderator, Alex Vrezo.
Thanks so much, Jennifer. I'd like to welcome and thank everyone for joining us today. My name is Alex Vrezo. I'm the HIV/AIDS Clinical Services Advisor at USAID here in Washington, D.C. For today's webinar, organized by AIDSFree, we've gathered experts who are going to speak about information technology tools that can be used to support the scale-up of viral load monitoring and early infant diagnosis. So one of the greatest challenges in scaling up viral load and EID testing across multiple countries that we've seen has been this issue with tracking patient data across multiple healthcare sites, as well as labs and instruments. Innovations in information technology can help us decrease the burden of data collection while also improving the accuracy of the data collected and enhancing the timeliness of data use in order to identify and address issues quickly and efficiently. Innovations in IT can positively impact clinical management towards the 90-90-90 goals. So today we'll hear 3 presentations on information technology for viral load and EID scale-up, including the connectivity platform aspect, formerly GXAlert. We'll hear about USAID Nigeria's experience with the aspect tool. And finally, we'll hear about Kenya's experience with the viral load and EID dashboard. I'd now like to introduce our first speaker, Brad Cunningham, who's currently the Vice President of Implementation and leads the South African office of SystemOne. Brad will be presenting today on the connectivity platform aspect. So Brad, I want to turn it over to you for our first presentation.
Thank you very much. Appreciate the opportunity to speak with you guys today. I'm just waiting for the slide deck to load on my end. So while waiting for that, as mentioned, I'm Brad Cunningham from SystemOne, and I head up the implementation team for SystemOne implementation and support for the countries that we're involved in from the South African office here in Johannesburg. Glad that we got the opportunity to speak with you guys today. So for those who don't know SystemOne too closely, the background to what we do is we're really a company that focuses on connected diagnostics and really on disease intelligence for global health. And our primary focus at this point really is infectious disease diagnostics, pretty much exclusively in low to middle income countries being Africa, the Middle East, Southeast Asia, and South America. And what we do is we provide platforms that do real-time data reporting. So a collection of diagnostic information from diagnostic instrumentation and then making sure that that data goes to where it needs to go. And the way we do this is by developing what we call an active data network, which really makes sure that the information collected from the diagnostic instruments is sent into the ecosystem that needs to consume that data, whether that be the patient, the clinician, the doctor, any additional information systems, aggregated systems, patient identification. And when we talk about this diagnostic data, we're really talking about the data, we're really looking at two different sets. The first one being the diagnostic data, and this really is data focused around the clinical management of the patient. So anything that helps inform the clinical treatment for that patient to improve the patient outcome. And the operational data. And the operational data is more looking at your key performance indicators for your diagnostic instrumentation. So looking at your error rates, your invalid rates, instrument utilization, and a number of your operational metrics that you really look from a national aggregated level at. And this data really can be transmitted to multiple levels of stakeholders, and there are a number of different stakeholders that need to consume this data in different ways, especially for something like HIV, for viral load and EID testing. You've got your national level, you can look at your community burden, all the way down to your clinician level, showing providing the clinician with the HIV result and the patient information and how to contact that patient, as well as letting the patient know that their result's ready, so that they can go back to the clinic and actively seek care to try and prevent loss to follow-up and get these patients onto treatment faster. And the whole purpose of the system really is to enable rapid detection and response to diseases and diagnoses to improve patient care. So we really include in the slide to have a look at how connected diagnostics has evolved over the last 5 years. And the use case at the moment in front of you is looking at gene expert connectivity for TB diagnosis. And this, the same parallels can be drawn with HIV, but just showing how rapidly this field is actually evolving in terms of digital reporting, e-health, medical IoT, whatever you would like to call this. But it really is an industry that 5 years ago didn't exist and really has taken off in a significant cascading model. Almost exponentially, we're looking at 15% more results being reported year to year from the previous year. And SystemOne's footprint with GXAlert and the Aspect system at the moment is currently in 36 countries with just under 1,500 instruments connected. I think as of today, I'm pretty sure we're well over 2.5 million results. And on the right-hand side there, you can also see the 529,000 notifications. So those are your real-time notifications that get sent out that are triggered on the system to help the patients the doctors get the patients onto treatment faster. And the evolution of the connected diagnostic space, not just for TB, but really has helped impact the way that the governance models have been formed and shaped around this industry in terms of the legislation, the data ownership, and the management of patient information into your health ecosystem and further cascades. So we are getting a little bit of background noise from one of the participants. And this also helps the various donors looking at your instrument purchasing and your purchasing cycles. Really having some transparency in terms of how these diagnostic instruments are functioning in the field. Really helps the donors review the return on investment. This level of transparency really does promote a higher confidence in the country to make sure that there is further investment after the initial placements. The obvious one is the faster result reporting, which is really one of the key focuses and really the genesis and the nucleus of the GXAlert and Aspect platforms, is being able to take a result from a diagnostic instrument and get that result back to both the patient and the treating clinician, whether that be a nurse or a doctor, to get patients onto treatment faster and improve your retention and care and reduce loss to follow-up. And we've actually had some really spectacular use cases from a number of different countries. I'm looking at some of the TB data that we've been reviewing, with pre-implementation of these systems, looking at from date of diagnosis to getting the patient onto treatment anywhere between 30 and 60 days. And we've got some fantastic use cases showing that with the post-implementation of these systems, it's actually reduced the time to treatment to 2 days of these patients, which can have a significant effect on the patient outcome, but also really improves your retention and care for these patients. And stockouts and expirations, we know that the consumable management for centralized labs is often difficult to do. based on the testing forecasting. But with the upcoming technologies for point-of-care diagnostics for HIV, viral load, and EID, managing consumables at dispersed centers when you're looking at 100 to 200 plus facilities in the country, this really does become a very difficult coordination effort. And the system really can help not only prevent stockouts and expirations, but virtually eliminate these based on the reporting structures that the system can provide. So what does this look like? How do we actually connect up these results? So if you guys will follow me at the bottom left-hand corner of the slide, you can see the diagnostic instrument. For this example, I've used the GXAlert, mostly because that's our primary base at this point, so it can do viral load and EID. Basically what we do is we place some hardware and some intelligent hardware at the point of the diagnostic device, which we call a connector. For Aspect, this is the Aspect connector. For GXAlert, it's a very similar model. And what this does is this is an end-to-end service provided by SystemOne, which makes sure that that hardware stays connected and stays reported. So we take care of the network, the management, the SIM cards, and the data, so that TB groups can focus on TB, HIV groups can focus on the HIV results rather than needing to negotiate with the network providers, manage SIM cards, APNs, firewalls. We take care of all the technicalities on that. And then what happens is, as soon as the sample has been run on that instrument and that diagnosis is available, our system grabs that result from the instrument and then sends that up to the GXAlert or Aspect server. Now this can be either our secure web-based system offered by SystemOne or an in-country server for those countries that would like that option internally. And then once the results are available on the server, that's really where the intelligence and the data activity starts, and the information really gets disseminated further into the ecosystem. So at the top left-hand side, you can see an operational view, something like a program manager at the Ministry of Health. You can see which of your instruments are up, which ones are reporting, which ones have stock, how much stock do they have based on their current stock levels, when will they have a stock out, or how many cartridges will actually expire based on their current consumption. So you can look at both overstocking and understocking opportunities on that. And it can help you manage your supply chain, your logistics, your instrument warranty, calibration, and really make sure that these instruments stay up and providing the diagnosis and meeting the expectations that the country needs from these platforms. And then there's also the aspect of further integrating this into other systems. So we know that patient management is becoming more and more important for meeting the 1990 goals. And so feeding this data into systems like OpenMRS, DHIS2, DISA-Lab, ETB managers, the HIV registers, really is a critical component of these systems that's able to integrate these results further into the continuum of care. And as these platforms grow and as they mature in the market, they're also expanding into the different disease spaces. So as I said, TB is the primary market for SystemOne, but our next big focus is scaling this up for the HIV and EID market, as well as HCV, Zika, Ebola, and a number of other infectious diseases that will also be available early next year. So what this really looks like is a snapshot of our dashboard here. We're looking at your disease intelligence, and I think this was mentioned a little bit earlier, that the primary concern initially is collecting data. But there's a couple phases to the progression of that. The first one is, can we collect data, and how do we collect this data? And the connected diagnostics industry, I'd say pre-2014, was all about proving that you can actually collect data from these instruments in very remote or rural settings. I think we've answered that question consistently, saying yes, we absolutely can. Now that we have that data, you want to do some analysis with that and provide some form of information. And that's really what the national level interpretation is, looking at the information that's being provided in terms of error rates, utilizations, your invalid rates, your so we can
I just spoke with him a while ago.
Okay, and so really when you're looking at this dashboard for the disease intelligence, this really helps you provide a lot of that information that you need to manage a program at a national level. And once you move beyond the information phase, so the first one is analyzing the data to provide you with information, and then it really is connecting the dots on the various information sources to provide you with some form of intelligence, which really is where we want to get to with these platforms. So rather than just looking at, consumption rate of cartridges versus ordering versus a lab procurement cycle, you can now start planning the future procurement automatically. The system can tell you when to reorder, how often to reorder for these facilities. You can make sure that your capacity meets your targets, your burden in your different regions, not just in terms of a community burden, but in terms of throughput requirements for your high and low burden districts, as well as identifying users on the system automatically for targeted retraining. If somebody has not had sufficient training on the system, which is resulting in a number of errors and invalids, then the system can actually start automatically identifying these people and calling them out on the system to provide the targeted training. And also looking at your customized data collection. Historically, diagnostic instruments provide the operator very little ability to provide additional information. So typically you've got your sample ID, your patient ID, and then a generic notes field for some more information. And there's been an increasing need from the community and the diagnostics community at large, requiring more information to provide a much richer data set. So having the ability to collect things like your patient's name, age, gender, contact information, referring facility, adds a number of dimensions that you can start stratifying this data to. You can start looking at, HIV cases for female pediatrics or TB HIV co-infection rates. I mean, it really does add a significant richness to the data set to allow you to be able to do some intelligent reporting around disease burdens in the country. And then looking to address the 1990 goals, Natasha, our PhD scientist, actually found a really great slide looking at monitoring the progress towards these is currently being blighted by poor data and poor quality reporting. And this article from PLOS Medicine actually sums it up quite nicely, showing that only 2% of the global HIV burden actually have good HIV reporting, and only 9 countries in sub-Saharan Africa have any surveillance data at all for viral load suppression. And really, when you're looking to address that third 90, the data reporting is probably the most critical factor in having any trust and any reliability in the reporting of that data. And so this really is an opportunity for these systems to provide an intervention that really can help with that. And we've seen this proven in the TB cases, and the TB world has adopted these significantly. And generally, the TB world has lagged behind HIV, but I'd say this is probably where it's moved one aspect in front of it. And HIV, I'd say there's definitely going to be similar parallels in terms of the adoption rate, if not a higher adoption rate than that of the TB world at the moment. And from a SystemOne perspective, we really see the role of connected diagnostics in the first and the last 90s of the Unit 8 1990. The first one really being your screening and your getting your patients onto care and getting some form of digital touch point for the patient into the system so that you have the ability to track the patient and follow them through the continuum of care. And that's not just capturing, this is a new patient, this is their name, and some form of identification. We know patient identifiers are a tricky topic at best. But also looking at things like integrating rapid diagnostic tests and your ability to do capture and quality assurance on those. And the obvious one being the viral load monitoring and suppression, your last 90, making sure that you actually have reliable data that you can trust, and the ability to somehow at least see the cascades of patients, if not track patients individually through that. So far I've been focusing really on the data collection and interfacing the instruments and connecting the diagnostic data from the analyzers. An Aspect Reporter really is a product that's currently in pilot by SystemOne in Malawi, looking at the dissemination component. So typically we collect data from the diagnostic instruments and then provide real-time actions via SMS or emails. And the Aspect Reporter is a different nuance on that, providing a lot more sophisticated and intelligent mechanism for result dissemination. And basically what Aspect Reporter is a touchscreen tablet that's physically mounted at a clinic that's seeing the patients and collecting the samples. This tablet has also got a solar power system and battery backup, knowing that in low to middle income countries, power issues are often something are a daily occurrence, and this really shouldn't hamper the treatment of patients. So it really is a self-contained system that's always on and making sure that the results are being collected. And basically what the system does is the clinic will collect samples for patients and send these to a referring facility. Once these are processed at the facility on the HIV platforms, like the Abbott M2000 or the Roche, as soon as those results are approved by the lab staff, the Aspect Reporter is a system which receives those results back to the clinic and allows the users at the clinic to log into the system to see their HIV, their EID, their viral load, and their TB results. And it automatically flags results that, for viral load above 1,000 copies, or samples that need, or patients that need to have an additional sample taken or be retested. So it really can help significantly reduce the turnaround time from the results delivery from a centralized system back to a reporting facility in order to get the patients onto treatment faster. So overall, SystemOne, the way we're looking to help address the viral load monitoring and patient monitoring and the Unit 8 1990 is really three different aspects. So from the labs and the clinics, at the lab side you have the Aspect Core, which I've been mentioning, which is really your data collection mechanism. So integrating the analyzers that are actually performing the testing and getting these quality results in a reliable and efficient means to be able to provide them into the ecosystem. The Aspect Reporter is really the receipt of these results at the referring facilities and the ability for the staff to receive those within 60 seconds of them being processed on a laboratory analyzer, and really help significantly reduce the turnaround time for getting these results back to the clinics. And then the supply chain is one of our products which is still in development, which really closes the loop between the clinics and the labs, where now it's not just labs that are collecting samples, clinics collecting samples, sending them to the labs, and waiting for the results. You can actually now start the ordering process so that the labs can also factor this into their workflow and integration with existing laboratory information systems for order processing. A lab can say that they have collected 5 samples, these are the details for these samples, and also provide intelligent information to the couriers on courier routes, which ways they should do that, and really try and optimize the supply chain mechanism and feed this data automatically onto the laboratory analyzers and allow the lab staff to factor this into their workflow and again provide as many efficiencies as you can in terms of the turnaround time from sample collection to reporting these results back to the patients and getting the patients back onto care. And with that, that is the end of my presentation, and I will hand back over to Alex.
Wonderful. Thank you so much, Brad, for that great presentation on Aspect. Please go ahead and continue adding questions for Brad into the Q&A box for our discussion session, which we'll have after all presentations today. So before we continue to the next presenter, I'd like to remind everyone to please press the mute button if you're joining by phone to minimize background noise. Thanks so much. Continuing the discussion on Aspect or GXAlert, the next presentation is from Debby Nongo from USAID Nigeria, who manages the USAID Nigeria flagship tuberculosis project, Challenge TB. Debbie, over to you.
Thank you, Alex. Good morning, good afternoon, maybe good evening. My name is Debbie, like Alex said. I work in the Office of HIV, AIDS, and TB at USAID Nigeria. I've had the privilege of being the guinea pig for one of the guinea pigs for the introduction of GXAlert in Nigeria. This journey started sometime in 2013 with a proof of concept for notifying NDR cases real time, and then we saw the potential to use the system to help us close the loop or the gap in diagnosing PLHIVs with TB and linking them to treatment. So that was how we got into this journey with GXAlert, and we've actually come a long way. So before we move on, I'd like to start with some basic background on Nigeria for those of us who aren't familiar with our programs. Well, we're first in the world for a TB burden, and we're highest in Africa. Our estimate is close to 600,000 cases per annum, but we're currently just over 100,000 at around 17% case detection. We have quite a lot of service delivery points, almost 6,000 dot sites and almost 2,000 microscopy sites. And we currently have about 377 GXAlert sites, and that's still growing, by the way, and 8 TB culture labs. As you can imagine, Nigeria being as big as it is, I mean, people constantly say we have 37 countries in one. It's a huge challenge to get anything moving, and getting data from sites up to the national level for decision making is a nightmare as well. And then let's not even get into like getting the systems operational at the site level, but we figured GXAlert was a godsend for us because this gave us real-time visibility into all our expert sites in country. So like I said before, this started out as a proof of concept with notifying MDR diagnosis real time, and then we saw the potential to do more. And this slide basically shows what our journey was like. It's been interesting. Like every time we do one thing, we're like, oh yeah, we can do this thing extra, and then we do something else, and then we're like, yeah, but you can do this as well, and then we do something else. SystemOne has been really responsive in accommodating our requests and helping us navigate through this. We started out with a USB modem that had like one SIM card and one service provider, and that became an issue because service provision would go down, and then we wouldn't be able to get data from the site. So we, at some point in 2016, we changed from the USB modems at the site level to 3G routers that could allow us to accommodate more than one service provider for data access. And that really improved connectivity at the site level, and I'll get to that, the issue of connectivity later on. But we currently have about 283 machines that are connected out of the 377, and that connection is still ongoing. I'll get to that as well later on in the presentation. So why are we connecting? On the right-hand side of this slide, you would see how information flows through the TB program, and this process takes usually about 6 weeks at the end of the quarter before we're able to see any information, if we're lucky, at national level. So we currently have TB local government supervisors who go to the TB facilities within their LGAs and physically record data. At the end, once a quarter, they'll have a review meeting at the state level where that data is collated, and then the following week, within that same, this process starts after the quarter ends, by the way. Then there's another review meeting at the regional level where the data is collated, and then it's sent to the national. So like I said, this journey can take up to 6 weeks, sometimes 8 weeks. So we would get data when it's too late to make any decisions that would impact change or fix anything. So we had instances where if an expert machine was down, we wouldn't know until like 2 months after it's broken down, or if it broken down at the beginning of the quarter, then we wouldn't basically find out until like 5 months later. So GXAlert basically made it easier to connect the facilities, to connect the decision makers, to connect the NCP, to connect the patients, because they would get, like Brad had already talked about how we send messages to patients to come back to the facility when their results are ready. So in theory, this system is supposed to connect all these key stakeholders in basically making sure that once a TB patient is diagnosed, that it starts treatment on time. So I don't know if I'm clear now. I heard that I was being scratchy. Right, moving on. And the expected results of this connectivity was that we will get real-time feedback to patients, to clinicians, and program staff on test outcomes. Program staff essentially for MDR diagnosis. And then real-time notification to the state program, like I said, on MDR, and an early warning system for non-functioning machines, cartridge stock level, warranty expirations, and QA issues. Timely reporting on the appropriate indicators as well. And then, more importantly, site-level visibility into functionality, because this has been an issue in Nigeria with modules breaking down or like sometimes backup power failing and stuff like that. So I'll give us a reality check now. Everything I've given you is how it should be. What is actually operational, or rather what's actually happening. I'll start with the successes. Like I said, we've got 298 out of 377 machines connected. And this process has been one of our success stories in terms of collaborating between donors. So USAID and Global Fund have partnered with this in a very seamless way. We basically funded the initial rollout of GXAlert. Well, beyond the proof of concept, we funded the initial rollout through a mechanism called through Associates. And we basically paid for the infrastructure, the development of the dashboard, and rollout to 200 sites. And then subsequently, GS picked up from there, and they are now rolling out to an additional 100 sites. And once that is exhausted, USAID will continue from there. So it's been a really good donor collaboration with this activity. Another success story was expanding the original concept to go beyond MDR notification to addressing TB HIV data needs. Like I said before, we had a challenge with linking the two programs in terms of referring HIV patients for diagnosis, but then once they're diagnosed, making sure that they started TB treatment on time. So GXAlert helps us sort of track that diagnosis and then subsequently improve our linkage to treatment. Another great success story was the buy-in for the National TB Program. As you can imagine, technology solutions tend to be kind of a challenge with getting the NTP's buy-in, especially at the local level. But with GXAlert, we didn't have any of those hang-ups. Everybody loved the fact that once an MDR patient was diagnosed anywhere, that the relevant authorities would basically get a text message notifying them. So that was a good selling point. So buy-in was practically 100%. The other success is the wealth of information that we have at our fingertips. I mean, the dashboard gives you so much information. It tells you number of tests done per site. It gives you information about like quality assurance issues. You're able to tell if a machine is offline and how long it's been offline for. I mean, it's a lot of information that is available. However, this is what is actually happening in country right now. Who actually has access to that information? Currently, the National TB Program is the administrator to this dashboard, or to the system actually, and they have restricted access to basically, access to the dashboard in this case, to basically themselves. People who currently have access outside the NCP are people who, I like to say they have illegal access because the NCP doesn't actually want them to have access. And I strongly believe this is a disservice to the system because we have implementing partners who support this site who are unable to get visibility to the dashboard so that they can tell what's going on in the sites that they support. These implementing partners are closer to the site, they're at the state level, and are able to respond quickly if there are issues, but they don't know that there are those issues going on because they don't have visibility. The government staff at the state level and the LGA level have access in the sense that they receive information when an MDR patient is diagnosed, but nothing beyond that. They can't make program decisions based on other operational information that should be available to them. We still have issues of cartridge stock out in country, even though GXAlert is installed in most of the machines, because the people who are responsible for distribution are unable to tell when the sites are running low on cartridges. They only get that information if someone picks up the phone and calls, and even then the distribution plan isn't done like that. They would have to wait until the end of the quarter when the reports are collated and sent up to the national level before they're able to start figuring out distribution plans for the next quarter. So like I said, even though we have real-time information, the people who have access to that information are very limited, and we are still struggling with getting access to real-time information and making decisions based on those information. The other issue is, if you can see on this slide, you'll notice there's a lot of sites that show inactive. Now this could be for a host of reasons really, but we don't know, because like I said, the IPs that support this site don't have access to this dashboard. So they're unable to tell if a gene export machine in one of their LGAs is down, and they need to go figure out why the machine is down. So connectivity continues to be an issue. We've been on site visits where sometimes we find out that maybe someone was cleaning, the router was knocked off, got disconnected, and they couldn't put it back in, or they didn't know how to, or they escalated it to the wrong person, maybe the state QA officer, who is a TV person, who is an IT savvy, who is scared to even touch the system. So it could be a host of reasons really why a machine might be inactive. Maybe a module is broken down, there's something wrong with it. But bottom line is, the people who can respond to those issues don't know when those issues come up real time. They have to wait until information is collected at the end of the quarter and sent up to the national level. So I've basically explained this slide already. The current practice is that the NCB IT staff, who is responsible for monitoring this dashboard, updates the lab unit. It could be weekly, monthly. I'm not entirely sure how often he provides that update. However, the IPs and us get an update from the NCP lab unit once a quarter to resolve issues. So regardless of whenever these issues happen, we only find out about it once a quarter. The data that is available on GXAlert or from GXAlert is not used for reporting currently. I don't think it's because not all the sites are connected. It's just because the program is used to reporting from the paper-based reporting system. Like I said before, we're still not using the inventory module, so logistics planning isn't done based on the real-time data that we have from GXAlert. What we're proposing is that access should be expanded at least to the implementing partners who support this site, so that they're able to make decisions, in a timely fashion and respond to issues more quickly. We're also hoping that the program will use GXAlert data real time and not quarterly, and that it would ensure proper use of the inventory module at least. And that's not saying the other modules are not important. I wanted to highlight some of the lessons learned from our experience with using GXAlert in country. The first issue is the NTP's reluctance to expand access to dashboard. I know I've gone on and on about this, but we see this as being one of the critical things to actually maximizing the potential for this system. We've had a lot of dialogue concerning this issue, and we continue to have that dialogue, and now that Global Funds is also supporting the system, we're hoping that as the two main donors for the National TB Program, if we approach this together with one voice, that we might gain more traction. But beyond that, we're hoping that now that the country is actually using more of the web-based electronic tools, because the TB program now has an electronic register. They're using eTB Manager as the electronic register, and we're working with SystemOne to see how we can seamlessly link GXAlert diagnosis information into eTB Manager, that they would understand why it's necessary to use this information instead of just having a nice system and relying on text messages to notify NDR diagnosis, because that's essentially what the NCP uses the system for now. That we realize that there's a lot more potential, and there's a lot of value added that the system can provide. And the other thing that we're also hoping for is we've sort of pulled our procurement and distribution of cartridges, and it's right now being managed by one entity. So that's another bargaining tool. If this IP, our supply chain mechanism, has access to the system, then they would be able to respond to stock out or plan better, have better supply planning, so that we stop having issues with stock out. And now that the country is using GXAlert as the first diagnostic tool for TB, the reliance on GXAlert, or rather the GXAlert machine, and the need to have more visibility into that machine should also help us get to the point where the entity will understand why it's critical to have more people have access to dashboard. And then the other lesson we learned is that because we didn't approach this initially with that mindset of basically defining user agreements from the onset, the NTP or the people who own the system didn't really understand what it meant and essentially what would be required down the line. So there's a misconception about having access to data and maybe using it for different purposes or for studies that the NTP might not be aware of, that it's forming their actions and restricting access. So this has been a critical lesson for us, and we're trying to see how we can fix that using the new platform that's coming in country, Omni, but then kind of tying all of the diagnostics into that, having user agreements that clearly define the access, who has access to what information and at what level. The other major lesson learned would be in terms of operational issues affecting the success of using GXAlert in Nigeria. One of major gaps we've noticed is the availability of support at any level, really. At the site level, we noticed that once the system was installed and the lab staff was trained, that was it basically. There was no SOP or some sort of manual available for any other person who might come later to kind of just go through it and understand what to do, or for that lab person who might have been trained in a day or two to go back to and basically have questions answered if you wanted to understand stuff better, or if they'd forgotten stuff that they've been told. We found instances where lab staff didn't know where to enter number of cartridges received, for instance. We had other issues that were still sort of based off of the fact that that support was missing. The other critical element of support that was missing was the fact that anytime there were issues of connectivity, they would have to escalate them to the national level and have one person travel to each state or each LG or each site to fix those issues, and that support wasn't really available closer to the site level at the state, for instance. And one of the things we're hoping will change is that the implementing partners who support this site would have some sort of training or SOPs or guide on how to troubleshoot and fix issues that they can fix. But in a nutshell, the entire issue around support has been a gap. It wasn't, I guess we didn't think about it at the beginning, but it's become very obvious that without fixing that, we're going to continue having issues of connectivity, and that's something we struggled with for a while. And in summary, what we're hoping to do in the next phase is to sustain connectivity and maintain it at a much better level than we have it right now, to figure out the issue of a unique patient identifier that would help us integrate GXAlert to other electronic platforms like ETB Manager, the PHIS. There's a CHAI platform as well that tracks diagnosis. So whatever platforms that might come up in future as well, if we can figure out the issue of a unique patient identifier, that might help us connect these systems better. And then, like I said, we're hoping that we'll be able to figure out the issue of providing timely maintenance support to sites, and that we can also connect the system to other diagnostic tools so that we're not reinventing the wheel and having different systems for different diseases or different diagnostic equipment. And that brings me to the end of my presentation. Thank you so much. I'd like to turn us back over to Alex.
Fantastic. Thank you so much, Debbie, for that great presentation on USAID Nigeria's experience with ASPECT GXAlert. A quick update for those of you who are trying to enter your questions into the Q&A box. It will appear when we switch to the discussion period slides after all the presenters have finished. So the next presentation is from James Batuka from USAID Kenya and Jackson Hungu of the Clinton Health Access Initiative, CHAI, who will be presenting today on Kenya's experience with a viral load and early infant diagnosis dashboard. So James and Jackson, over to you. So I think we might have James and or Jackson still on mute. So if either of you want to go ahead and unmute yourself, then we'll be able to hear you. Thanks. Okay, it looks like we're having a issue getting James and Jackson back on. So why don't we just hold on for 1 second while we confirm that they are still on the line and haven't dropped off. So just 1 moment. Okay, it sounds like we still do have James on the line. We are just making sure that his sound is unmuted through the online system. So thanks everyone for your patience while we bring this next presentation on board. Hi, James, I think we can hear you now.
Can you hear me? Because I can hear you loud and clear.
Wonderful. We can hear you. Go ahead.
Okay. Thank you. So I was saying that my name's James Batuka. I work for USAID Kenya in charge of treatment. I'm presenting this with my colleague Jackson Hungu from CHAI. He's the Deputy Country Director for CHAI Kenya. Again, we say this is part of the cooperation as development partners in the country. I'll be talking about both the EID and viral load dashboards in Kenya. Just to give you a brief about Kenya is we built a successful EID and viral load network. We do our testing in 8 labs with a platform of about over 30 machines. We currently doing about 100,000 tests per year, but with a capacity of 2 million tests in a year. We do not procure equipment in Kenya. All our equipment's on placement. Just the next slide talks about our network. Basically, our network is built around the patient and how the samples move from the patient to the health facilities, to the courier system, to the hubs, to the testing labs, and then back to the patient. And that's what I'll be sharing, how this works. So I'm going to say, how did we start? What is the history behind the dashboard? So basically the dashboard started about 8 years ago with EID, because when we started rolling out EID, we found that there were challenges in the labs in terms of scheduling for testing and testing. So it was initially designed to assist the labs with testing, being able to make sure that when samples come in, they can be able to prioritize and test them. Then it evolved to a national dashboard, which was linked to the courier system, whereby when the facility samples were received, because the samples were taken by the courier to the labs, the moment the samples are received in the lab, the facility got a notification showing that the sample has been received. From there, then we moved to the next level, which is about the testing of results and then emailing of results. Then 3 years ago came viral load, and with the viral load we realized, because with EID we were doing about 50,000 tests there, but then came viral load where we were doing hundreds or tens of thousands of tests in a month. So testing became a big challenge in the lab. So again, because we had designed the system to help basically with the testing and the scheduling right in the lab, we basically had to improve the automation and made sure that there were no losses, because again in the beginning we were having issues with lost samples, with delays in results and so on. So we built it on that background to address the issues of improved testing, delayed results, lost results, inefficiencies of a slow system which had been used for EID, and demand for data by the programs. Again, we learned from the CD4, because when we as a program in Kenya right now, we have over 1 million tests, 1 million people on treatment, but we couldn't really have clear information about CD4 when we used to use CD4. So we decided that we needed to have a good system to make sure that when it comes to viral load, our viral load database is clear, our viral load data can be followed all through. So again, based on the platform that we were using the same labs and the same machines to test, we again just worked to make sure that we improve this system. So we got money from PEPFAR 2 years ago to really improve the system. We bought hardware but also worked on the software, and the numbers have since increased, like I said. I mean, going to innovations in the program, what have we done on this program, which is, and I forgot to tell people, I know that our website is open, and if you want you can be able to log in as I present this. Again, we looked at what were the challenges. One of the challenges when we were beginning viral load was data clerks. We went to the labs and there was slow, there were backlogs because of the data clerks. We found that all the lab people had been turned into data entry clerks because the number of samples which were coming in were so high. So again, we had to innovate around that. So in that we introduced what we call a remote login, whereby people would be able, facilities would be able to log in onto the lab system, enter their information about the samples, age, unique number, regiment, and so on and so forth, and then just deliver the samples to the lab for testing. We also designed the system to make sure that it can pick data from the EMRs directly for those, so that you can pick data and stop all the data errors, so that you can pick that data, go, and when the results come back, then it's direct into the EMR. We also created what we call hubs. Again, we extended this technology to big facilities, which could then collect samples for the small facilities and be able to enter into the system and then deliver the samples to the lab through courier. We've also been able to innovate through what we call a USSD code, so that in case a clinician is with a patient and they have not received their results, you send a text message at no charge and you're able to get the results of the patient. We've done electronic notifications to facilities where when they are able to log in and get their results, they can also download results. And this applies both to EID and viral load. Right now we've also gone to direct notification of patients. So for EID patients, we notify them when the results are ready, and for viral load patients, we are delivering results. The the basis is that we believe for the viral load patient, he should be able to get his results. For EID, we think the mothers still need to go through counseling and other processes before we deliver the results to them. So we ask the mothers to come back. Again, we are doing real-time monitoring for testing, looking at backlogs, looking at program performance, and I'll be going to the next slide just to show you how that works. So if you look at that slide, it represents basically what I would call the face of our dashboard, which shows the number of tests we are testing every month. If you can check there, I think that's the month of May, we did over 100,000 tests. It shows the summary, the trends, the regiments, and so on. So again, we've designed the website in such a way that you just open and you can be able to see a lot of information you need. I mean, the others for this one in particular shows because in Kenya we have counties instead of districts. So again, this shows the separation and volumes across the various counties. So again, it's by just click of a button, you're able to see that information and be able to look at the county. This next slide, which you can see, it allows us to analyze the trends over time. Again, it shows our testing, and this is for EID. It shows our testing for EID since 2008. So again, you can see that as a country our number of tests have been increasing, but our positivity is reducing, which is a good thing. So we're able to track this. This particular slide represents our analysis for regiments. Again, we're able to pick a regiment and look at the number of tests done per regiment, the separation rates, the gender, and the age distribution in that regiment. The next slide allows us to look at an analysis by age and by implementing partner. Again, we're able to pick different age categories and understand what's being done, the number of tests done, the separation per age category, per county, and per partner. That next slide basically shows about partner monitoring. In Kenya, we have over 50 partners that are doing viral load. We have over 3,000 facilities doing both viral load and EID, but we again able to look and to check how the partners are performing. We're able to look at number of tests done per partner, look at separation, look at their trends, check in the counties where they are working, how they are suppressing. Again, you look at their age data. We're able to look at their facilities and be able to pinpoint which facility is not performing well or which partner. Nowadays, actually, when we go out for quarterly meetings, we basically ask the partners to open the dashboard, and we're able to discuss right there using live data. Again, looking at this one, this dashboard allows us for monitoring of facility performance. So this is what you'll be seeing basically at a facility. So again, when you open a facility, it will show you the facility name, it will show you the test, it will show you the trend, it will show you the separation, the rejected samples, you see the age, the gender, and the trends at that facility. So again, when you're at a facility, you're able to see, or if you're a facility provider or administrator, you're able to go in and see exactly. Now, as I said, our website is open, but we also have areas where you need login, because we have certain information where we don't want, for example, somebody to go in and see for AIDC positivity of patients. Again, I would emphasize that we don't have names in there, but again, we also don't want, because somebody could pick somebody's number. So that is based on login. So facilities can only log in and see their patient data. They can look at results for patients and details. Partners, sub-counties, and counties can log in and see the performance of their facilities. They are able to look at the different facilities and be able to manage them. This again, because we're having challenges with the labs and monitoring them, we created what we call the dashboard, viral load dashboard, or EID dashboard live. In here, we're able to see real time what is happening in the lab at that certain moment. So it's a real-time monitoring. So we're able to know what the lab is testing. We're able to know if they have samples in process, if they have samples which are tested but not yet approved by the lab manager. We're able to know if they have backlog. So we read monitor that, and we're able to see all our 8 labs and get to monitor. So that helps us if we find that a lab has high volumes, we're able to move that to another facility or to ask them to move it to another lab so that they are not really building up backlog and delaying. Again, this is about our turnaround time, and again, when we look at this turnaround time, when we started, we're at about 42 days, and when we talk about national turnaround, we're talking about from the time of sample collection to the final day when the patient gets results. So again, we've been able to reduce this. For EID, we are below 5 days. For viral load, we're at about 10 days right now. We're moving to make it 5 days. Of course, one of the things I want to say is that in Kenya, about 50% of our samples are DBS, and sometimes they have to take some time because of the transportation system, so, and the correction. So we able to look at all these trends per lab at also a national level to know what is the time from sample collection to receipt in the lab, the time from receipt to testing, the time from testing to release, and per lab and per national level. So again, we're able to follow up all that. Again, this slide talks about how we are delivering. We know that we've been asked to make sure that patients are getting results in time, and we had a challenge last year when we did a service quality analysis. We found that whereas the results were available in the website, the patients were not receiving them. So we designed a number of things to make sure, one, facilities can log on to the website and get their results, but we've also encouraged most of our partners, because we've created what we call an API, which allows exchange of data with EMRs. So we're encouraging most of our partners to make sure that they are connecting the EMRs with the viral load website, so that then results can be delivered straight, because it is painful when the results are there and the patients are going home without results. Again, like we talked about, we are doing transmission of results to clinicians through text messages. We're also doing it by email, and now we have started transmission of results to patients, which is great. So far the patients are so happy because they go home today and then tomorrow they get their results and they are happy. And we keep saying one of the greatest things is when a patient gets their results and they are suppressed. They really feel so good about it. Again, I'll talk about what we call interesting facts about our EID viral load result system. One of the things is that we call it cost effective because this has been designed and maintained by Kenyan students. We use graduate students who keep doing this and they keep improving. That again has allowed us to do so many things. It allows us to continue doing continuous improvement because again the students are here, it's easy for us. We are not contracting somebody and giving us a big bill. We have these students, we pay stipend and we can sit with them as they build their careers. They also promoting or contributing to national development. So we believe that has been very, very good for us, and that's how we've been able to move. Again, we have no names in the system. Like I said, we have only patient numbers, but we've also built the system with all the security requirements to make sure that nobody hacks it or whatever. So we put in firewalls. With the PEFA funding, it really helped this improve. It improved the speed. Like I said, it's cost effective. It's not dependent on high maintenance. There are no user fees. There are no external parties. We do not have licensing fees. Again, we keep changing based on need. As needs come in, recently we had requests from PEFA asking for some of the indicators to be changed for EID. We're able to go in with our programmers, look at it, and be able to change and make sure that some of these indicators are involved. Before I say thank you, I want to request my colleague, I don't know whether he's back online, if he can say one or two things which I've missed. I now have 2 more minutes. Jackson, are you there? Okay, it seems we don't have Jackson on the line. So thank you very much. That's the end of my presentation.
Great. Thank you so much, James, for that excellent presentation. We're going to now use the rest of the time for discussion. So the Q&A box is now active, so please go ahead and type questions for our presenters into that box. We will try to get to as many questions in the time that we have remaining today, which is about 25 minutes. Any questions that we don't get to during this time will be collected, and we'll ask the speakers to share their responses. Those responses to the questions will then be posted on the AIDSFree website following the webinar. So let's go to our first question. And our first question was about connectivity. So the first two presenters talked about electricity in sites being a barrier to rollout of GXAlert or aspect in those sites. But the person asking the question asked if those two presenters could maybe touch on a bit about internet connectivity and how that has or has not been a barrier to GXAlert rollout. So I'll pass that over to Brad and Debbie. Thanks.
Yeah, thanks for the question. Connectivity traditionally has been an issue, but we have a couple of things working in our favor at the moment. Mobile, at least mobile and 3G penetration increases year on year. It's one of the largest investments in developing world infrastructure at the moment versus fixed line. So 3G penetration is continuously improving, and so is the hardware. When you're looking at supporting these rollouts with off-the-shelf solutions, you are going to run into issues. Wi-Fi dongles, I think Debbie will agree from the Nigeria experience, works fine for 10 days, works okay for 30 days, and after 60 days, there's really no hope in that. So there are specialized solutions that you can actually, that we use to support at least for these rollouts that really are designed to work in fragile connectivity environments and areas where there is no low connectivity. And so you can specifically buy hardware that is designed to work in these environments for that. And also the migration towards global SIM cards. So a SIM card that can roam on multiple networks, which allows you not just to focus on a single network or manage relationships with multiple network providers. Having a global SIM card that can connect to any available network really does make the SIM management easier. To address the issue on the power, we work in a couple of facilities in some regions where they may have a power loss not just for 2 to 3 hours a day, but for 2 to 3 months a year, and that can be a significant hurdle in patient treatment and care in terms of reporting if they don't have solar backups for these facilities. I hope that answered.
Yeah, and this is Debbie. I'll just like to add the Nigeria perspective. So you look at connectivity from two sides, the data and then the power, like you've rightly mentioned. Power is an issue in Nigeria, it continues to be an issue. When we install GXAlert machines, we'll always make sure there's backup power, either using inverters or now we're moving towards solar power backup. So the inverters need to be charged, of course. Hopefully the facility would have a generator that would charge it. And generally, our expert machines are installed in the secondary facilities that should have backup power. So that sort of addresses the power issue. And then the other part is the data connectivity. So when we started out initially, we had the USB modems that would basically hold one SIM card, so we were restricted to using one network provider, and that quickly became an issue. So we moved to the routers that allows us to connect at least 3 SIMs. So we're able to have a cocktail of network providers so that if one fails, the other one kicks in. And then we sort of tailor them to the environment. Like I said, Nigeria is very different. We've got 3 major providers, MTN, Glo, and Etisalat, and they don't all work at the same capacity in the same places. So we basically have to have a cocktail of network providers so that we ensure that there isn't too much of a downtime on the data side of the connectivity. I hope that answers your question.
Thank you, Debbie. The next question is for James. You mentioned the unique identifier that's being used. Can you clarify what unique identifier is used in the dashboard since the names are not provided?
Yes, I was actually going to ask my colleague to take that so that he can say something. They need to hear his voice if he's on.
Thanks, James. I mean, with respect to unique identifiers, patients are identified basically by the health facility and details such as sex and age, etc. Keep in mind that they are only useful to the extent that you have another system that deals with patient information, such as an EMR. If an EMR exists on the other side, then they obviously have generated their own unique identifier with respect to themselves. Hence, it doesn't become an issue when you start aggregating the data to the extent that you're sending it to systems such as DHIS and others. But there has been a lot of conversations around the whole idea of patient identifiers, if you want to do longitudinal studies or longitudinally follow up patients. We've always maintained that, this is a program tool, this is not an EMR as it stands. If one wanted to, longitudinally follow up a patient, then they would have to go either do a chart review or go into an EMR system. One other thing I wanted to add very quickly was that in Kenya we believe in open data. We fundamentally believe that people closest to the patients, when provided with information, could provide the interventions that are really required. Hence, we have developed an API that gives facility level summaries to the day on just about any dimension of data that you see on that website, which means anyone can take data in near real time on a daily basis and build their own dashboards, build their own notification systems for their own facilities, for managers at county facility level, sub-county level, for any level. We just want to ensure that the system as a whole functions by making data largely available. Thanks.
Great, thank you. So the next question is from Susan White, and this is specifically for Brad with respect to Aspect. So the question is, how does Aspect or GXAlert differ from DAT winners and CommCare platforms? Where is GXAlert more effective? So Brad, over to you. Thanks.
Yeah, thanks for the question, Susan. CommCare and DAT winners really are mobile-based platforms that focus on the clinical management of patients. Mobile health and the mHealth arena is a significant field in connected diagnostics. And that really focuses on, at a clinic level, providing workflow assistance and guidance for healthcare workers on clinical management. And so where GXAlert really fits into that is the ability to deliver results to those kind of platforms. So GXAlert typically would interface with something like CommCare and provide the information to the healthcare worker that would enable them to treat the patient. So GXAlert doesn't provide clinical guidelines or patient management. GXAlert's role really is to gather the diagnostic data and then integrate this with any systems which use that. And that's where its cost effectiveness comes into play, is integrating multi-disease, multi-device diagnostic instrumentation and then feeding that data into the systems which need to consume it.
Great. Thank you so much, Brad. And Jennifer is going to ask the next question, so I'll just turn it over to Jennifer.
Great. Thanks, Alex. So the next question is from Lewis. Are there offline means of results distribution? We heard from you, James, about the use of SMS, but can you tell us in the Kenya example, and then also for other presenters, what format or design are results being distributed offline?
Yeah, thank you very much. Actually, maybe as I was rushing through, I forgot to mention that again, all these electronic delivery systems are additional to the paper result movements. So we have a courier system which goes to the lab. So the labs print out results, signed results, and then we have a courier G4S in the country which picks them and takes them to the nearest, what I call them towns or trading centers, to the facilities, and the facilities are supposed to pick them from there, or the partners help. So that system, the manual system, is in there. But we put in the electronic system to make sure, because what we found that the manual system was taking a bit longer. Sometimes results will be in the facility because they're at the lab and the clinician who is seeing the patient doesn't have the results. So the electronic result is additional, but the manual results finally get to the facilities and they are put in the file.
Great, thanks so much. I wonder, do any of the other presenters, Brad or Debbie, want to answer that question about offline results distribution? Have there been any kind of country-specific examples, I mean, with Nigeria, or perhaps, Brad, countries that you're working in where you're aware of different offline results distribution systems, maybe SMS or anything else that you've heard of besides SMS?
Yep. So this is Brad. At the moment GXAlert uses SMSs quite extensively. We send roughly between 30 and 45,000 SMSs a month for real-time notifications, for alerting clinicians, patients, MDR facilities about patients and the patient results. But there are, of course, limitations to what SMSs can do. It's a good distribution platform, and the general consensus in the field is it's not great practice to send results by plain text and SMS because there's no authorization to see who's actually viewing that, so there is a confidentiality issue. You don't know that the person receiving the message is actually the person intended to receive it is not the one reading it. And also just the ability to acknowledge that somebody has actually received that result and done something with it. You really want to, rather than just providing the data, make sure that there is an action taken on that. So SMS is a good way to do the data provision, but no way to acknowledge receipt or action of that data, if that makes sense.
This is Debbie. I wanted to talk about the transmitting results offline. So like I said, in Nigeria we use SMSs, but essentially to notify MDR diagnosis. So the patient gets a text message saying your result is ready, please go back to your health facility. The program staff, in this case, would be the TBLS, that's the local government supervisor, who manages the lowest unit of the TB program, would get a text informing them that a patient has been diagnosed with MDR in a particular facility. The lab person will get a text message saying, contact the TBLS with information of the patient. So there's different text messages that go out to different people, basically informing them of what the next action to take is. But like I said, that's around MDR diagnosis. For normal TB diagnosis, we don't rely on SMSs to send information. We currently still rely on paper results to initiate treatment, and that's a program policy essentially. We've got a sample transport mechanism that we use in country called Riders for Health. They are tasked with delivering samples to the GXAlert site and also returning results. So they pick up samples dropped and then pick up results from the samples that they dropped before and take them back, and turnaround time has reduced now to less than 3 days. So we're kind of happy with what GXAlert is doing, where they work, and for the rest of the country, essentially we rely on the paper results and not SMSs for normal TB. We only use SMS for MDR. I hope I answered the question as well.
Thanks so much, Brad and Debbie. That's really helpful to hear. Thanks so much. I just wanted to ask Debbie a follow-up question. So you mentioned in your slides that Aspect or GXAlert is in the process of being rolled out to 377 sites. But for those who are joining from countries that don't yet have GXAlert or are interested in piloting this technology, maybe not only for HIV but for other diseases as well, could you speak a little bit about how this was initially piloted in Nigeria?
Like I said, it started with a proof of concept, and the scope was basically limited to MDR. And it was initially essentially supposed to help us with knowing when an MDR person was diagnosed so that we could quickly find the patient and have them start treatment. So the tool at the time was installed on 50 GXAlert machines and tested the possibility of getting text messages out, and that was the original proof of concept. Beyond that, we started talking about building the dashboard so that the results could be viewed at the central level. So the original pilot was basically focused on MDR, but let me take us back. When GXAlert machines were introduced in Nigeria in 2013, the focus was actually MDR and not TB diagnosis. In 2010. It was 2013 that sort of began to change, with PEPFAR pushing for the diagnosis of TB and PLHIVs with GXAlert. At that point, the program started to shift the focus from just MDR to TB diagnosis and PLHIV as well. And then we were struggling with linking patients to treatment. So this became clearly an opportunity to quickly figure out how to get the results back to the clinicians and to the patient, or basically to get the patients to get back to the facility to let them know that results were ready. Because we had a hard time with getting clinicians to start people on treatment based on a text message. But we figured if we could just get the patients back to the facility to see the clinicians because they knew the results were ready, then we would shorten the amount of time to treatment. But yeah, so the pilot started with just 50 sites, and it was essentially using text messages to send out results. And then eventually we had the dashboard built so that we could have more visibility into the system. And then beyond that, we quickly rolled out to the 200 sites, like I mentioned. I don't know if that properly answers the question, or if you need me to explain a bit more.
Yes, that's very helpful. Thank you so much, Debbie.
Thank you, Debbie. And just a reminder, please continue to type your questions into the Q&A box. The next question is from Susan White, and it is for Brad. GXAlert relies on the quality and efficiency of labs to achieve accurate results within timeframes. How does GXAlert address the quality of labs, which can vary widely across countries?
Yeah, thanks for the question, Susan. I probably disagree saying that GXAlert doesn't really rely on quality and efficiency of the labs. But I mean, it really is a tool that is focused on trying to ensure both quality and efficiency. Once you have data being reported from a diagnostic platform, like an Abbott or Roche or a GeneXpert, when you start looking at the aggregated and the metadata on those results, I mean, there's a wealth of information that you can actually dive into in terms of quality assurance. You can pick up a potential lab contamination, you can pick up sample rejection rates and whether those guidelines or algorithms are being adhered to, as well as your utilization and efficiency. You can see when people start testing, when people stop testing, if the lab's operating 24 hours, who's running those tests, monitoring the individual users. So I'd say GXAlert's not reliant on their efficiency, but it really is a tool that can be used to improve efficiency and quality in the labs. There's a lot of fascinating workflows you can actually pick up when looking at the data. One of the countries that we worked in, we noticed that there was a number of duplicated samples. So for GeneXpert, this country was collecting 2 samples up front for diagnoses, and the duplicated samples were always being run on a Monday because the person running them on a Friday was different from the shift who started on a Monday. They just leave the samples in the fridge without telling somebody that they'd already been run. So there's really fascinating laboratory workflows that you can actually investigate with this data once it's available, if that answers your question.
Thank you, Brad. Are there any other questions to share? Otherwise, I think we can go ahead and respond actually to Timothy's question as our last of today regarding mechanisms that were put into place that have supported the Abbott and Roche supply system in Kenya. If you can take that question, James.
Yes, thank you very much. When Tim says mechanism, so again, like I said, Kenya is a big program. We have over 1 million people on treatment. We have a few labs, like we said, 8 of them, which we call regional labs or central labs. So we monitor well. So what we did is we used an interesting concept of simple competition, where we negotiate with Roche, and then after we negotiate with Roche, we also go and negotiate with Abbott and agree with things. And what we've told the two vendors, the two main vendors, is that our next procurement will be based on the consumption of the reagent. So in short, that if I buy reagents and your machine breaks down, then I will not buy next time. So we also agreed with the vendors that if the reagents expire in the country, they will replace them. So the vendors now are motivated to make sure that the machines are running all the time, because your next order depends on how well your machines run. So that has really helped us to be able to move forward. It's also one of the things which helped us to get price breaks, because again, we keep saying, I think we have the lowest price. Maybe South Africa may have a better price, but apart from South Africa, I think we have the lowest price around the world. So what we've done is we use that, and if a machine breaks down, because in the beginning when we were starting, that was an issue, and we told these guys, if your machines break down, then I get the other vendor to supply more, and if they supply more, then they get a bigger order. What that has also done is we find that the vendors are active, so they manage the commodities with us. Most times the vendors will call you and say, by the way, we need to start ordering. So we share all this information, and it's one of the things which Jackson explained. That's why we have an open dashboard, because we want everybody to know what we are testing. Roche is able to go to that dashboard and get to know how many tests are done, but we've also agreed their machines have systems for monitoring, and they Abbott, so they know what's in our central warehouse. So they are able to advise us and say, we need to order, or this is happening. In addition, we've seen that even for technology, for example, Roche offered us their biggest machine before even we asked, the C8800, which does basically 1,000 tests in one shift or 2,000 a day. So again, they offered it before even we asked because of the competition, and they, like I said in my presentation, this is offered free of charge, free of maintenance, we do not pay anything. Our responsibility is to make sure that we have adequate resources to keep buying reagents, because we believe that that's how they make money. So it's their responsibility. Actually, one time I was in Swaziland, and I said it's what we call the Matatus Theory here, because for us here, Matatu is the transport system. If your Matatu breaks down on the road, all the passengers get out and go to the next. So we use that, and we've told them that's how we work. If your machines break down and you don't maintain them, because the lab have the other alternative platform, the lab will move to the alternative platform. So that has been the key issue. But we've also started introducing other platforms like the Panther to start increasing the competition even further. Thank you. I hope, Timothy, I addressed your question.
Thank you so much, James. Before we wrap up, we would like to again thank all of our speakers today for sharing their time and expertise, and thank you to all participants for attending and for this rich discussion. In a few days, you'll be receiving an email with a link to today's webinar recording. Before we sign off, I wanted to encourage you to take a moment to fill out the poll questions on your screen, as your feedback will really help us to improve future webinars. I'd also like to encourage you to visit the AIDSFree Viral Load and Early Infant Diagnosis Knowledge Base, and to sign up on the AIDSFree website to receive updates on the knowledge base. We are continually adding new resources to the knowledge base, and encourage you to share with us guidance and tools that you're using to guide the scale-up of viral load testing and early infant diagnosis for inclusion in the site. Thank you all once again, and enjoy the rest of your day.
Thank you.